these guidelines are released in August 2025, which have described both myocarditis and pericarditis. So myocarditis and pericarditis are inflammatory diseases of the myocardium and the pericardium respectively, with potential overlap. So in these guidelines, they have introduced a new term, that is IMPS, inflammatory myopericardial syndrome. So it is basically an umbrella term during the which is used during the initial diagnosis until a final diagnosis is made. And IMPS ranges from isolated myocarditis to isolated pericarditis, and also mixed form with possible reciprocal involvement such as myopericarditis and perimyocarditis. So they have shown this spectrum that pericarditis and myocarditis isolated also can be present, and myopericarditis or perimyocarditis can also be seen. So whichever is predominant, so in myopericarditis, pericarditis is predominant, and in perimyocarditis, myocarditis is predominant. The rationale for the introduction of the term IMPS is that myocarditis and pericarditis have similar etiologies and are anatomically continuous structures with possible secondary involvement.
Myopericarditis which is predominant?
Pericarditis. And in perimyocarditis, myocarditis is predominant. So these are the definitions and terminology which they have mentioned, that IMPS is an umbrella term for both the syndromes. Myopericarditis has predominant pericarditis, and perimyocarditis has predominant myocarditis. Acute myocarditis is when the duration of symptoms is less than 4 weeks. Fulminant if the patient is hemodynamically unstable and requires inotropes or mechanical circulatory support. Complicated myocarditis includes acute myocarditis with any one of the following, that is EF less than 50% on echo, so we are discussing the 2025 ESC guidelines for myocarditis and pericarditis. So they have introduced a new term, that is IMPS, inflammatory myopericardial syndrome, which is basically an umbrella term for both myocardial and pericardial syndromes. Myocarditis is basically in which there is predominant pericarditis, and perimyocarditis has predominant myocarditis. So they have introduced this term because they have a potential overlap. Another term which they have said is acute myocarditis, that is the same as before, that is duration of symptoms less than 4 weeks. Fulminant is a subtype of acute myocarditis in which there is acute onset and hemodynamically unstable patients which require inotropes or circulatory supports. Complicated myocarditis is acute myocarditis with more than one of the following, that is EF less than 50% on echo, or any sustained ventricular arrhythmia, advanced heart block, heart failure, or cardiogenic shock. Acute pericarditis is again duration of symptoms less than 4 weeks. Subacute or ongoing myocarditis is more than 1 to 3 months, that is. Same way, incessant pericarditis is again 1 to 3 months. And chronic myocarditis or chronic pericarditis is when the duration of symptoms is more than 3 months. There is also one more thing, which is inflammatory cardiomyopathy, that any chronic myocarditis in association with cardiac dysfunction and ventricular remodeling with clinical phenotype of hypokinetic, either dilated or non-dilated cardiomyopathy, with or without any arrhythmogenic substrate. So that is inflammatory cardiomyopathy. Recurrent myocarditis or pericarditis is new symptoms or disease after activity after clinical remission. And so in IMPS, inflammatory myopericardial syndrome, there can be remission without residual or remission with residual. So remission without residual is when there is absence of symptoms, normalization of ECG as well as the biomarkers and imaging abnormality. So if everything is normal after the acute episode, it is remission without residuals. And remission with residuals is when there is persistence of abnormality on ECG or biomarkers on imaging, but the symptoms has regressed.
Inflammatory myocarditis शब्द अलग थी क्या आपका मीनिंग करो?
सर એ એટલે જે હવે permanent chronic changes થઈ ગયા due to the chronic myocarditis.
chronic का जो जरूरी तो inflammatory myocarditis की definition जो है तो मुझे बता भी दे.
So if chronic myocarditis is associated with ventricular dysfunction or remodeling leading to a cardiomyopathy, then it is inflammatory cardiomyopathy. And a chronic myocarditis without anything.
So, inflammatory myocarditis cannot, cardiomyopathy cannot present acutely. That is the point.
Sir, heart failure is a presentation of myocarditis.
So you cannot label it as an inflammatory till 3 months of symptoms.
Once we have confirmed the diagnosis of myocarditis,
Now I got it.
etiology of myocarditis is most commonly presumed to be viral. Enterovirus, adenovirus, parvovirus B19, Epstein-Barr virus, HHV6, as well as influenza and coronavirus are most common virus associated with myocarditis. Bacterial infection with Borrelia species, that is Lyme's carditis, and parasitic infections such as Trypanosoma cruzi, that is Chagas disease, they are also additional etiologies. So these are the infective etiology, and the other part is the non-infective etiology, which mostly involves all the autoimmune diseases, that is SLE, systemic sclerosis, rheumatoid arthritis, eosinophilic granulomatosis with polyangiitis, hypereosinophilic syndromes, giant cell myocarditis, eosinophilic myocarditis, and cardiac sarcoidosis. So basically they have divided the etiology into two parts, infective and non-infective.
डेंग्यू वायरस आ नहीं, डेंग्यू वायरस नॉर्मल मायोकार्डिटिस
આપણા દેશમાં પણ બહાર
मिला
એ લોકો સર નતું મેન્શન ગ્રુપમાં આપણે
COVID-19
કોરોના વાયરસ તો એ મેન્શન
કોરોના એટલે આ બધી યુરોપિયન કહ્યું ને
European.
clinical presentations of myocarditis.
Most important toxin related mean આવ્યો ને scorpion sting માં થઈ શકે.
Ah, yes, sir.
So you should at least mention.
Clinical presentation, there are 4 types of presentations. First is the chest pain presentation. Chest pain is the most common form of clinical presentation, that is in about 75% of the cases. And it is commonly associated with increase in the biomarkers, such as that is troponin. Along with that, there is ECG alterations, in which most commonly it is ST segment elevation. So this basically mimics ACS, but there is absence of a single obstructive coronary artery disease, significant obstructive coronary artery disease, and these cases are basically labeled as infarct-like myocarditis. And patients with this presentation usually report a recent or concomitant viral infection, such as respiratory tract infection or GI tract infection, which often precedes the myocarditis by several days to weeks, that is around 2 to 4 weeks. Second presentation of myocarditis is heart failure presentation, that is the patient can present with acute heart failure in particular when associated with LVEF less than 40%, and that is basically considered as a high risk group. Clinical presentation also range from unexplained impaired ventricular function with or without dilated LV, new onset or worsening heart failure, usually over 2 weeks to 3 months, to rapidly progressive refractory heart failure and cardiogenic shock. And arrhythmias can be a presentation of myocarditis also, as well as it is an alternative cause of heart failure outside the suspicion of myocarditis. Third presentation is arrhythmias. Patient with acute myocarditis with new recurrent or unexplained arrhythmias may have a wide spectrum of symptoms ranging from palpitation to syncope, even to life-threatening arrhythmias causing sudden cardiac death. Supraventricular arrhythmias, especially the supraventricular arrhythmias, are mainly seen when there is concomitant pericarditis along with myocarditis, while the ventricular polymorphic and irregular ventricular arrhythmias are more commonly associated with isolated myocarditis. And patients with advanced AV blocks or sustained ventricular arrhythmia should be considered as high risk even in absence of LV dysfunction. VF and sudden cardiac arrest also occurs in about 2.5% of myocarditis related to hospitalizations. And polymorphic or irregular ventricular arrhythmias are more common during the active inflammatory phases, whereas when there is healed myocarditis with cardiomyopathy, then the arrhythmias are mostly monomorphic cardiac death, that is, causes of sudden cardiac death in young adult is myocardial inflammation associated with fatal arrhythmias. Sudden cardiac death attributed to myocarditis among autopsy patients ranges from 1.1 to 12%, and males show higher incidence rates of sudden cardiac death than females. Most individuals are asymptomatic before sudden cardiac death. However, between 18 to 48% of patients present with symptoms including viral illness, malaise, syncope, chest pain, palpitation, etc. So these data highlight the need to suspect a diagnosis of myocarditis early.
Yeah, so the way those are typical symptoms. Any such viral infection patient comes, that patient is under observation. I will suspect he is heading for myocarditis.
So if
आता चेस्ट पेन તમે હાર્ટ ફેલ્યો એરિથમિયા સમજી ગયા ચલો સડન કાર્ડિયક ડેથ when patient is in ward તમે સવારના રાઉન્ડ લઈ રહ્યા છો બરાબર કઈ દેખો કે you suspect કે myocarditis develop છે.
So, one is in clinical routine practice, if the patient has chest pain, we do
ચેસ્ટ પેન એ તમે ચાર સિમ્પટમ્સ થઈ હું તો એની વાત નથી એના સિવાયની વાત.
In that cases, if we have biomarkers also elevated.
નહીં બાયોમાર્કર થી તો તમે ક્લિનિકલી you are taking round તમારો એસિડિન કહે છે કે સાહેબ આટલા ક્લિનિકલ ફાઇન્ડિંગ્સ છે.
So clinically, so it is
unexplained tachycardia. Fever now હોય ત્યારે 99 100 pure and 140 pulse rate હોય. That is indicative that something wrong is going on in this patient. Patient is not complaining. આ બધું તો તમને હાર્ટ ફેલિયર થયો છે તો વેરી લેટ સ્ટેજ unexplained tachycardia or tachycardia out of proportion to the what patient complains for that. આ બધું હવે ક્લિનિકલ બધું જતું રહ્યું છે.
So they have given the spectrum of myocarditis, presentations and outcomes. So there is a wide spectrum, that is the patient can be oligosymptomatic, chest pain, arrhythmias, heart failure, fulminant, aborted, sudden cardiac death and sudden cardiac death. So all these presentations there can be remission without or with residuals. So with residuals means there is presence of reduced ejection fraction or reduced hemodynamics function. Patient can lead to a dilated cardiomyopathy and any of the following can lead to death also. So this is basically the spectrum of multiple presentations with different outcomes. So there are stages of myocarditis. First is acute myocarditis. So as we said, less than 4 weeks. Typical symptoms and signs and presentation are chest pain in more than 80% cases, dyspnea in 20 to 50% cases, and fatigue, palpitation, syncope are less common and are reported in about 5% of the cases. Majority of the cases, that is 80%, the symptoms are preceded by prodromes, in which fever is 60% cases, GI in 30% and respiratory in 25%. ECG is normal in the minority of patients only, that is about 15%. Most frequently the ST segment elevation is present in 57.5%, but other STD changes can also be found in 23.5% as well as conduction blocks in 10%. And in acute myocarditis, most of the patients will have cardiac enzymes elevated. So fulminant myocarditis is a subtype of acute myocarditis in which it occurs in 3 to 9% of the cases, in which it is characterized by cardiogenic shock at presentation for which hemodynamic support is needed. Biventricular failure also occurs frequently in fulminant myocarditis, and sustained ventricular arrhythmias in 46.9% of the cases, and some present with sudden cardiac death. Second type is a subacute myocarditis. So that is basically from more than 1 month to 3 months, and these symptoms are unspecific. Patient might either have a remission without residuals or might progress to chronic myocarditis or inflammatory cardiomyopathy. So subacute is a phase when there are no specific symptoms and patient may progress to chronic or inflammatory cardiomyopathy. And third is chronic myocarditis. Chronic myocarditis is present beyond 3 months. it basically reflects as an intermediate stage, possibly leading to inflammatory cardiomyopathy, and characterized by cardiac remodeling and some degree of ventricular dysfunction. Milder forms of chronic myocarditis may appear as hypokinetic, non-dilated forms of cardiomyopathy. Moreover, an arrhythmogenic substrate due to fibrosis should also be considered. Biomarkers have now in chronic myocarditis are usually within normal limits, and new quantitative CMR techniques, cardiac MRI techniques have improved the diagnostic yield in patients with chronic myocarditis. So diagnosis, first is ECG. ST segment elevation in 20 to 60% of the cases beyond a single coronary territory. Second is widespread ST depression or T-wave inversions, QT prolongation, low voltage QRS due to myocardial edema or associated pericardial effusion. So in echo, generally there is a left ventricular hypertrophy or myocardial edema that is seen, and with that we have a low voltage QRS. So that is, in that cases we can suspect myocarditis. Conduction abnormalities such as AV blocks, intraventricular conduction delay, different types of arrhythmias as we have mentioned, supraventricular as well as ventricular. And ECG changes are highly dynamic and may evolve over a span of hours or days, with temporal progression varying significantly among patients. And normal ECG does not rule out myocarditis.
Nothing specific.
Nothing specific.
Pericarditis is concavity of chest elevation.
Is concave of course if it is pericarditis. And in myocarditis they are similar to they are like convex surface only, but they don't they are not in one coronary artery territory, so they are beyond the coronary. Biomarkers, one is the markers of inflammation, that is CRP is elevated in about 80% of the cases. Myocardial, as we know that troponin is elevated, and assessment of baseline troponin is crucial to diagnose the severity of myocarditis. And markers of heart failure, that is NT-proBNP is also elevated, and baseline NT-proBNP is recommended in patients with suspected myocarditis because it is used as a predictive marker of heart failure among the patients with normal or impaired. There are a few markers which are beyond clinical routine, that includes tumor necrosis factor alpha, interleukin 1 beta, interleukin 6, interleukin 17A, interleukin 1 receptor like 1, that is IL-1RL1, procollagen type 3. These are all in research.
When interleukins are increased, again tremendously, you suspect a patient cytokine storm. वायरल फीवर वाला पेशेंट ने हमारा ये इंटरल्यूकिन कराव ने तो आउट ऑफ प्रोपोर्शन के मार्केटली एलिवेटेड हुआ है, तो यू कैन सस्पेक्ट यानी साइटोकाइन स्टोन.
Echocardiography in myocarditis, the global ventricular dysfunction can occur, diastolic dysfunction with preservation fraction can also occur, and regional wall motion abnormality may occur. So basically tissue Doppler imaging or strain imaging is used. So recent studies have shown that the global longitudinal and circumferential strain, that is GLS and GCS, which we generally do in the strain echo, they are decreased in the patients with acute myocarditis even if the EF is preserved. And increased LV wall thickness due to myocardial edema. So echo is again also not very specific for myocarditis. These are also non-specific findings only. But cardiac
will you differentiate with a close differential diagnosis called Takotsubo?
In this,
which echo finding will tell કે આ Takotsubo હોઈ શકે ને આ myocarditis હોઈ શકે, right? કારણ કે બંનેની etiology different છે અને presentation almost same, right? Takotsubo નું presentation and myocarditis નું presentation would be same.
It's not આપણે differentiate કરી શકે કે આ એડીમાં છે કે હાઇપરટ્રોફી છે.
ના, echo પર edema નથી, એના માટે cardiac edema હોય, પણ Takotsubo has specific findings.
Apical ballooning,
Apical ballooning or basal ballooning, reverse can be there, right? GLS માં specific sign for Takotsubo.
apical માં હોય એટલે ટાર્ગેટ bull like sign કે જે હોય છે જેમાં apical માં hypomotility જોવા મળે.
Yes, very nice. બરોબર તો ટાકોસુબો will be very peculiar lesion on GLS એનું ફાઇન્ડિંગ એકદમ જો તમે બુલ સાઈ લીધો હશે પરફેક્ટ આવશે બરોબર બટ માયોકાર્ડાઇટિસ માં એ નોન સ્પેસિફિક હશે ઇટ ઇઝ GLS will be increased of course but પહેલા જે પેટર્ન નહીં હોય ટાકોસુબોમાં that's the only differentiating feature on echo of course MRI માં you can have other findings
and even sir in markers also if the BNPs are more than
that is not reliable. No?
Yes.
It can be then vice versa. Right?
Cardiac MRI. So cardiac MRI has the advantage of tissue differentiation, non-invasively detecting the myocardial and pericardial inflammation as well as fibrosis. So basically there are three aspects which are seen in cardiac MRI in myocarditis. First is the T2 mapping, in which myocardial edema and changes due to inflammation leads to increased tissue water content, and that can be detected in the T2 weighted imaging. Second criteria is the T1 mapping, in which the tissue-free water is generally detected in the MRI and the extracellular volume quantification. And the third is the late gadolinium enhancement, that is seen in cases where there is myocyte necrosis or fibrosis. So there are non-ischemic patterns of LGE, that is late gadolinium enhancement, which do not typically follow a coronary distribution. So this is basically the T2 mapping, in which we generally detect the tissue water content in the, so basically the best imaging to detect myocardial edema. So these are a few images of T2 in which there is color coding, and according to the water content in the tissue, there are different colors which are shown. So this tells us that how much is the water myocardial edema. Second is the T1 imaging. So T1 measures the longitudinal relaxation times, which identifies the changes in the intracellular and extracellular compartments. So this indicates inflammatory hyperemia and edema, that is extracellular edema. And so these are again the color coding of T1 imaging. So this is the second criteria. And third is the late gadolinium enhancement. So gadolinium is basically an extracellular contrast agent, and it does not interact with the intact myocytes. And so it generally goes and accumulates in the myocyte necrosis and inflammation or fibrosis. Wherever there is damage to the heart tissue, it accumulates there. And normally whenever gadolinium is given, so there is a very fast washout from the normal myocardium and a slower washout from injured myocardium. So the images are acquired 10 to 15 minutes after the contrast injection. And if there is a gadolinium enhancement seen after 10 to 15 minutes, so that suggests that there is damage to the myocardial tissue. And that damage is now seen in the non-coronary territory, or more than one coronary territory, or non-ischemic patterns of LG. So
LG માં હજી એક પોઈન્ટ ઇમ્પોર્ટન્ટ રહી ગયા. One you already said કે કોઈ particular boundary follow ના હોય. પણ તો multivessel involvement હોય તો double boundary તો LG માં મળી શકે. How will you differentiate from LGE of myocardial infarction and LGE of myocarditis?
sir, if there is a speckled pattern, then it is.
One is speckled patterns. પછી next distribution કેવું હોય? Infarct are typically subendocardial or transmural, and most of the time myocarditis are mainly subepicardial. Right? So these are another differentiating feature from which you can see.
So based on the MRI, this is the updated Lake-Lewis criteria, which now we can prove the diagnosis of myocarditis based on MRI. So as we can see that there is a T2 based criteria. T1 based criteria includes two things. That is, one is the T1 mapping and another one is the late gadolinium enhancement. And then there is supportive criteria. So in CMR proven myocarditis, if both, that is T2 and T1 criteria are present, then so both of the main criteria, if they are present, then we can label it as CMR proven myocarditis. So that is a definitive diagnosis of myocarditis. And CMR uncertain myocarditis is basically if there is only one criteria fulfilled, that is either T1 or T2, then it is CMR uncertain myocarditis. So recommendations is there is class 1B recommendation in patients in which there is suspected myocarditis to reach a diagnosis and to determine the cause of myocardial injury, including the assessment of edema, ischemia, necrosis, fibrosis, scarring. And once the patient has been diagnosed, then it is a class 1C recommendation if within first 6 months in patients with myocarditis to identify a healed or ongoing process and for further risk stratification and to enable a return to exercise. So that is in the first 6 months there is a follow-up cardiac. Next is endomyocardial biopsy. So there is identification of histological subtype of cardiac inflammation. It can be done by EMG. Important for high-risk patients and where targeted therapies are needed. And potential complications include perforation, tamponade, thromboembolism, valvular trauma. Endomyocardial biopsy also allows identification of the inflammatory stages and the degree of necrosis and fibrosis. So first, initially, EMB was based on the H&E staining, but then due to high inter-observer variability, now the definitions of diagnosis are based on immunohistochemistry. That is either we see there is lymphocytes CD3 markers or macrophages CD68 markers. And the most common site for EMB is the RV septum, but occasionally LV or biventricular EMB may also be needed. So this is the types of histopathological subtypes. That is, one is the H&E staining, and along with that there is immunohistochemistry. So based on both, now the histological types are mentioned. Like one is acute lymphocytic myocarditis, chronic lymphocytic myocarditis. So in acute there is more of necrosis, and chronic there is more of fibrosis. And according to the CD3 and CD68 markers, the predominance of cell is determined. Next is eosinophilic myocarditis. Another one is giant cell myocarditis or cardiac sarcoidosis. So these are basically histopathological subtypes which are seen by endomyocardial biopsy. And the recommendation is class 1C in patients with high risk myocarditis. So basically high risk myocarditis are the patients which have hemodynamic instability and or intermediate risk myocarditis not responding to conventional therapy. In order to detect whether there is any specific type of myocarditis and whether a targeted therapy is needed. So this is basically a paradigm shift which they have shown in the diagnosis of myocarditis. So in 2013, cardiac MRI and clinical findings, they were mentioned as suspected cases, proven only with the help of endomyocardial biopsy. Then within this time span of 2021-2023, clinically there was suspicion of myocarditis, cardiac MRI confirmed it, and proven cases were only the one which had endomyocardial biopsy. And now with these guidelines in 2025, we can even prove myocarditis with the help of cardiac MRI. That is EMB or CMR proven myocarditis, EMB or CMR with uncertain results, and that is possible myocarditis, and EMB and CMR negative, that is unlikely or rejected myocarditis.
સાહેબ એ વિડિયો હું છું પિરામિડ માટે ક્લિનિકલ શબ્દ જ કાઢી નાખ્યો.
Diagnostic criteria for myocarditis. First is definite myocarditis, that is as we said that there is clinical presentation is present. Along with that there is either cardiac MRI or endomyocardial biopsy is proven, then we will tag it as definite myocarditis. Possible is in which the CMR, cardiac MRI or EMG have uncertain results or they are not available, and we have a clinical presentation with at least one of the following criteria, that is non-specific that is ECG findings, STT changes, troponin elevated, and imaging shows abnormal strain, wall motion, reduced EF or myocardial edema on CMR findings. And third is unlikely or rejected, that is only clinical presentation and without any additional criteria.
રિસોર્સ લિમિટેડ સેટઅપમાં તો તમારો છેલ્લો ક્રાઇટેરિયા ડેફિનેટિવ થઈ જાય. પણ મારો ક્વેશ્ચન એ છે કે ધ coronary angiography is mandatory, either CT or invasive in this patient to rule out, or ખાલી આના પર જ જતું રહેવાનું?
જે લોકો એક ફ્લોચાર્ટ આપો છે કે પેશન્ટ કઈ રીતે મેનેજ કરવું, તો ઇન ધેટ વી હેવ મેન્શન્ડ કે ઓબ્સ્ટ્રક્ટિવ કોરોનરી આર્ટરી ડિઝીઝ નથી, પછી only you go ahead with the cardiac.
પણ ડિસ્ક્રિપ્શનમાં નથી લખ્યું.
આમાં diagnostic criteria માં they have not mentioned anything about the coronary.
That's a dicey thing. આપણે સમજદારી ઉપર ને ક્લિનિકલ પ્રેઝન્ટેશન ઉપર છોડી દીધું છે.
એટલે કમ્પલસરી કરવું તો પડે જ નહીં.
તો પડે ને. અને આપણે તો ક્યાં કાર્ડિયાક આ પેશન્ટને એમઆરમાં કોણ મેળાડ આપશે?
કરે છે વડોદરામાં કાર્ડિયાક એમાં
હા સર, બહુ રૂટીનલી થાય.
આવું આ ગેડોલિનિયમ ને બધું જ
હા
કરે છે.
ગેડોલિનિયમ તો સાહેબ બધું ઓલવેઝ કરે.
SRL માં વર્ષોથી કરે છે. અને પહેલા તો ત્યાં એનો મુંબઈથી એનું ક્રોસ રિપોર્ટિંગ થઈને આવતું.
Risk stratification. First is so we have divided into high risk, intermediate risk, and low risk. So any patient presenting with heart failure, cardiogenic shock, dyspnea grade 3, grade 4, cardiac arrest, syncope, VF, sustained ventricular tachycardia, high level AV block. So these all patients are high risk patients. Intermediate are non-sustained ventricular arrhythmias with progressive dyspnea and persistent release of cardiac enzymes. And low risk are stable symptoms of oligosymptoms. And same way imaging, if the EF is less than 40 and there is extensive late gadolinium enhancement, then high risk. If mildly reduced EF 41 to 49% and or preserved EF with CMR findings is intermediate risk, and low risk are EF is preserved more than 50% and there is very limited LG, that is less than 2 segments, or there is no LG on CA. So this is they have given the flow chart, that is the patient's
કયો છે બેટા?
ચાર બાકી
patient presenting with symptoms of myocarditis in ER, that is what they have mentioned. First is we go for the first line investigation that includes the cardiac biomarkers, history, physical examination, ECG, transthoracic echo, X-ray, laboratory assessment. Then first of all we rule out obstructive coronary artery disease. So they have mentioned that whether if the pre-test probability is high for coronary artery disease, then we go for invasive. If the suspicion is low for coronary artery disease, then we can go for CT coronary angio. After that, if it has been ruled out, then we have to admit the patient and based on the risk features, the patient if the patient is classified into high risk, then we go for endomyocardial biopsy in the class 1 indication. And if the patient is either in the intermediate risk or in the low risk, then cardiac MRI is the class 1 indication. And based on the CMR and EMB, we can say whether it is a possible myocarditis, definitive myocarditis, or rejected or unlikely myocarditis. And if there is definitive myocarditis, then we further go for risk assessment, that is if intermediate or high risk, we admit the patient in ward or ICU, and low risk we can admit the patient in ward. And then we have to establish the therapy and treatment of specific etiology, and further if there is improvement, then we have to go for a cardiac MRI if not done before. So if there is a biopsy which is done before, then we go for a cardiac MRI and discharge if possible. And if there is no improvement, then multidisciplinary IMPS team discussion. So this is the basic guidelines which they have given. Management. The medical therapy of myocarditis is based on clinical presentation, case severity, and etiology. So it includes the general supportive measures, the non-etiological directed therapies, that is heart failure therapy, anti-arrhythmia therapy, and specific therapy, that is etiology directed therapy. So mostly in almost all the cases, the corticosteroids are considered for autoimmunity associated cases as the first line therapy in most of the cases. Uncomplicated cases of myocarditis usually they present with chest pain and can be empirically treated with aspirin or NSAIDs for the control of chest pain. Beta blockers are often used in patients with myocarditis and are associated with better outcomes. Fulminant myocarditis requires inotropes, vasopressors, and even mechanical circulatory supports like IVP. And chronic myocarditis basically requires only the GDMT for heart failure. So this is a table which they have given for specific etiologies. So if it is a virus negative lymphocytic myocarditis, so again these are biopsy proven cases. So in these cases, the first line is if it is non-severe. So in most of the cases, that is lymphocytic, eosinophilic, giant cell, cardiac sarcoidosis, all of them have mostly the management is prednisone if non-severe, 1 mg per kg per day, and if severe presentation, then IV methylprednisolone for 3 days and then followed by oral prednisone.
So on which day of presentation you will subject this patient for EMB?
So if it is being stratified in the high risk, according to the guidelines, they have only mentioned that if according to the risk stratification only we can decide whether to go for CMR or EMB. So if the patient has arrhythmias, cardiogenic shock, maybe aborted sudden cardiac death or any kind of that presentation, then CMR is not possible in those patients. So those patients undergo EMB in the IPD.
So even if he is unstable, will you subject for EMB? How much you wait?
So according to the guidelines, the best yield of EMB is within 2 weeks of suspicion of myocarditis. So
Within 2 weeks?
within 2 weeks. So if the patient has been admitted, and so in the first 2 weeks we get the maximum yield. If the patient is turning into subacute or then chronic and then we plan an EMB, then generally the yield of the biopsy is less.
So those who are very severe, right, myocarditis, they are less likely to respond to just conventional heart failure therapy. You will agree to this point. Suppose patient came in ICU, right? You are trying to stabilize him for 3, 4, 5 days. Is not getting out of the ICU or hemodynamic instability, and now you need to decide steroid आपको anti-TG आपको you want an etiological diagnosis के आने का एक वधारे करिए तो empirical steroid आपसू के EMP छता भी करसू what is to be done?
Sir, in here if we don't have EMB which is done very commonly, so generally like we also had a case recently. The patient was stable, the patient came with chest pain, troponins were 15,000, 17,000. Echo was strain was there was presence of ત્યારે આપણે HOC Takotsubo जो picture લાગ્યું હતું because apical hypomobility હતી. But then we did cardiac MRI and which showed LG and changes of myocarditis. So that patient was given 3 days of IV methylprednisolone here in IPD and then discharged on oral steroid. So in very high risk, sir, so EMD is only possible.
Mention guideline માં કરશું.
But the best thing what we can do is we can give a trial of
steroids should be still considered.
Does colchicine play?
Colchicine, sir, they have mentioned that if there is concomitant pericarditis, then there is a role of colchicine.
More of a pericarditis than myopericarditis.
Perimyocarditis. Myocarditis predominant, pericarditis સાથે સાથે એવું ને?
હા, that is
તો perimyocarditis.
Perimyocarditis.
આપણે બી ચા પીધી છે.
What is the incidence of this? Yeah, is it seasonal also?
Sir, in epidemiology they have mentioned that the studies show very varied incidence and prevalence due to because the suspicion or level of suspicion is very low for them. And now with the increase of cardiac MRI, now the diagnosis we can confirm the diagnosis with cardiac MRI. So now the incidence is gradually increasing because most of the cases of acute myocarditis they go into remission. So there are so many missed cases of myocarditis because they come present, they get treated and then there is remissions.
Clinical criteria